Good evening, everybody, and happy Hanukkah to those of you that celebrate Hanukkah. This is the first night of the Festival of Lights. Tonight, we're going to talk about metabolic health, which is a very exciting topic and also a very important one because it essentially involves all of us to one matter or degree. First, I want to give you a little bit of alarming facts that only 12% of the American adult population is metabolically healthy, which means 88% are not healthy. And so really, what is metabolic health to begin with? Metabolism is very simply defined as the conversion of food into energy. So everything we do in life, eating, shaving, sleeping, studying, is all involves metabolism. So metabolic health is really defined as the absence of metabolic syndrome. And metabolic syndrome is based on 5 parameters. So we're talking about blood pressure, blood sugar, fasting blood sugar, HDL cholesterol, triglycerides, and waist circumference. So whenever 3 out of those 5 are abnormal or abnormally high, then you have what's called metabolic syndrome. And that's really what we're talking about. But look at that. If you look at the end of the spectrum, the end of the spectrum is basically talking about diabetics. And diabetes, remember from our time together 3 weeks ago, is basically metabolic syndrome gone awry. Okay, 30 million Americans are diabetics, and most of them don't even know it or are inadequately treated. By the year 2050, they expect it to be up to more like 50 million people. So it's pretty huge. But metabolic syndrome is based on those 5 parameters. And why is it so important? Because if you have 3 out of those 5 and you have metabolic syndrome, you are more likely to develop diabetes, heart disease, or stroke. So it's a big deal. Now, the study I want to cite for you was recently published in November 2019 in the Metabolic Syndrome and Related Disorders Journal. And that was where they found that only 12% of the population was metabolically healthy. Now, they studied 8,721 people. Now, their guidelines were such that you had to have a waist size less than 40 inches if you were male, less than 34.5 inches, or basically 35 inches if you were female, fasting glucose less than 100, fasting triglycerides less than 150, HDL or the healthy cholesterol greater than 40 if you were a male and greater than 50 if you were a female. And the blood pressure had to be less than 120/80. That may sound pretty stringent. And the other thing you need to know is that the people that were in this 12% club were on no medications at all. Now, what did they find positively? Who did the best? Well, females did the best. People that were more physically active did well. Younger population versus seniors, more educated, and of course, non-smokers. And who did the worst? Who did the least good? And that was the black race. Unfortunately, did poorly, and people with high body mass index or BMI. And the obesity population did less than a 0.5% or less than 1% for sure were metabolically healthy. It's a big deal because over 42% of the American population is obese by definition. So, but I want you to know that it's not just about your weight, because they found half of those that were underweight were metabolically healthy, and less than a third of those that were of normal weight were metabolically healthy. So the implications are such that although obesity ranks highest on the list for metabolic health, it's not just about the scale. So what can we do about it? Note that this was based on patients that were not on medications. That doesn't mean we give up. Even if we have to take medications to achieve these goals, we still want to achieve these goals. The first thing I always recommend is please know your risk. You should know your blood pressure. You should know your fasting blood sugar. You should know your lipid panel, and also you should know how to measure your waist circumference. So that's first thing is to know your risk. And what can you do about it? Well, if you smoke, obviously that's the first thing you have to get rid of. Smoking not only is bad for you in every possible way, but it also increases your insulin resistance, which is the last thing you want in metabolic syndrome. So it's pretty much out. Diet should be a low carb, anti-inflammatory diet. So I don't care whether it's vegan, Mediterranean, paleo, ketogenic, or anything in between. You really want to be low carb. Regular exercise is important. Sleep hygiene is very important. And also this thing called intermittent fasting, what you may have heard a lot about lately. Now, I do not recommend that everybody undergo intermittent fasting. Personally, I've been doing it for over 2 years, and it works very well for me. But there's been quite a bit of studies on intermittent fasting and people that have metabolic aberrations. And the person you want to read about is this Dr. Jason Fung, F-U-N-G. He's out of Toronto. He's published a couple of books, and fascinating person. You can find him on the web. And he has worked with some very ill patients, not just diabetics, but diabetics with kidney disease. And he has found that he could turn a lot of these people around with intermittent fasting and a low carb diet. So we'll talk about that some other time. The other thing is, what about COVID-19? Well, they found that people that end up admitted to the hospital, which is, I think, less than 80% of people with COVID-19 never hit the hospital. But those that do get admitted to the hospital, that have to go to intensive care units and be intubated, and or who die, have a poor metabolic health. So it really has an implication there as well. With that, I'm going to stop because I think, I want to give you just a primer on this. And now I want to take some questions from the audience, people that are watching about metabolic health and anything related to this. So please, anyone. Good. Here's one question is, okay, I like to be healthy and I exercise regularly, but I'm on medication for blood pressure and I'm a borderline diabetic. Does that mean I failed the test? And the answer is no. Yeah, they had to have strict criteria when they define what's metabolic health, but we still try to achieve metabolic health no matter what. We can get you to have a normal blood pressure, or desired blood pressure, with diet, exercise, and sometimes medication. And I can take a diabetic and make them into a pre-diabetic, and I can take a lot of pre-diabetics and make them into non-diabetics. It's all about lifestyle. So a lot can be done. Okay, which three are most commonly seen in a patient? This is really interesting, of those parameters. For sure, I would say the waist circumference is a big deal, because even though patients will come in, they'll say, "Oh, I weigh the same now as I did in college or high school," but they don't really realize that the body composition has changed. So although they may weigh the same, they've lost muscle and they've gained fat, and where they usually gain the fat is around the waist. So they do have an increase in waist circumference. A lot of people don't really see that until I point it out to them. The other thing is the blood pressure thing is a big deal, because remember, they use the criteria of 120/80. Anything greater than that, they would consider it higher risk. Now, most of us don't get their values quite that good. I go by the standards that were recently introduced about 3 or 4 years ago. So now we want to have your blood pressure less than 130/80. So if it's 131/81, you're considered hypertensive now. When I was a student many, many years ago, that was not even borderline. 140 was considered borderline. So we've changed over the years because we've learned that people with lower blood pressures do the best, not just metabolically, but they do the best. And they are the least likely to have strokes and heart attacks. So it's really important. So waist circumference, blood pressure, and this HDL cholesterol is an interesting one, because that's one of the parameters that we use. And there are a lot of people, even a lot of athletes, that have low HDLs, and that could be related to genetics, smoking, obesity, and thyroid problems. So those are what we commonly see. Okay, supplements that are helpful. I do use a lot of supplements. Most important thing is to control your blood pressure. So if we can control it with supplements, that's a great thing. So I use combinations of potassium. Potassium helps to lower blood pressure. Magnesium can be helpful. Coenzyme Q10 can be useful. Omega-3 fatty acids or fish oil. And I also have my own product, which involves something called olive leaf extract, which is not olive oil. It's the extract of the olive leaf that not only is that anti-carcinogenic, but also been shown to help lower blood pressure. And I found it to be quite effective in some of my patients. And I combine that with grapeseed extract and quercetin, which is an anti-inflammatory. Okay, that's a supplement I use for blood pressure. What about for blood sugar? Because remember, that's a big one. The blood sugar should be less than 100. That's your fasting. And although they didn't measure insulin, I'm a big stickler for measuring your fasting insulin level because that really gives me even more information. So important thing really is diet, low carbohydrate, no matter which of those diets you actually favor. But supplements are important. I use a combination of alpha-lipoic acid, which helps to improve insulin sensitivity. Also things like chromium, you've heard of chromium, vanadium, these are trace minerals. Also cinnamon can be very useful. And berberine. Berberine is one of my favorites. In fact, I have a product called Glucowise Plus for HeartWise, in which we combine these ingredients. And it's been very effective in keeping blood sugar at bay without going to medications. So there's really a lot you can do. And of course, combined with diet and exercise. Okay, what is a diabetic to do when using artificial sugars that affect your metabolic profile? Well, here's the thing with metabolics. I mean, the thing about artificial sweeteners, it's a big deal because it's been shown that artificial sweeteners actually increase your desire for sugar. And it's been shown that they actually increase metabolic syndrome. It's believe it or not, you crave sugar more. So it's not that people that drink Diet Cokes and Diet sodas and Diet this and Diet that do better. They actually don't. They have a high incidence of metabolic syndrome. So I try to dissuade people that have metabolic issues from taking artificial sweeteners. It certainly isn't ideal for this population of people. Can low blood pressure be a problem? I don't think so. Unless you're dizzy. I think actually low blood pressure, I have low blood pressure. My daughters have low blood pressure, so I think it's a good thing. Low blood pressure, you're really going to have heart attacks or strokes in most cases. So it's not a bad thing unless, of course, you are having symptoms, which is dizziness or passing out. I have a lot of in my 35 years of treating cardiac patients, the people, I can tell you with my hand on my heart, the people with the lower blood pressures do best. There's no question about it. That may be, it's still the number one risk factor for heart disease and stroke. Okay, can you please elaborate more about people with diabetes and COVID-19? Well, diabetes is, again, we talked about, this is all about metabolic aberrations, metabolic syndrome. So diabetes is like the end of the spectrum. That's like metabolic syndrome gone awry, as I mentioned. So it's like the tip of the iceberg here. So it is a major risk factor. We thought from the initial data that came out in China and Italy that heart disease, kidney disease, and diabetes, I think, I forgot the order, were the major risk factors that portend poor prognosis and death. Then we learned once we got to America, to New York, that really it's obesity. Obesity has become the major risk factor, which of course is a hallmark of these metabolic aberrations that we're talking about. In fact, now that we have younger people coming down with COVID, the people that do worse with the younger generation they tend to be people of color, obese, and sometimes with asthma. So it definitely lowers your prognosis. It's not good for your prognosis. At what age does metabolic disorders usually show up? Great question. Well, look around. Look at the youth of today. I mean, do they look healthy to you? I go into supermarket and I see fat kids, fat parents, and fat grandparents, and it's so I think it's beginning really early. Is there a genetic gene for metabolic disorders? I believe that we overdo this thing about genetics. I think about maybe 20% of the illnesses that we see, including metabolic disorders, is genetically based, but 80% is really about lifestyle. And that's what we can work with, but I think it starts with young. I see people in my office, 20s and 30s, high blood pressure, high triglycerides, low HDL, and they're obese or they're certainly overweight. Okay. At what point does HMG-CoA reductase inhibitors take precedence over lifestyle and a pre-diabetic? Okay. Wow. Great question. So HMG-CoA reductase inhibitors, basically it's statins. You've all heard about statins. They've been around for over 30 years now, and they're very useful in lowering LDL cholesterol, the lousy cholesterol, and they've had a major impact on decreasing secondary heart attacks and death and disability from heart disease. Now, it's funny. What about over lifestyle? It's not over lifestyle. To me, lifestyle is always number one. Now, a lot of people in my field in cardiology do not emphasize lifestyle the way I emphasize it. So they'll go straight to a statin on patients with high cholesterol, especially if they're diabetic. Because you got to remember, 70% of diabetics will have either a stroke or heart attack in their lifetimes. We're talking about a large number. We actually treat diabetics as if they had heart disease, even if they've never had an event. But I don't rush to a statin, because if I just give you a statin, I'm saying, listen, I know you can't do this on your own. So why don't we just start with drugs? So that kind of disempowers patients. When my role as a physician is to be your quarterback to help empower you to do that. Do I use statins? Absolutely. Is my threshold low in diabetics and in those with heart disease? Yes. But I still emphasize lifestyle first. That's a great question. There's never such thing as a stupid question. I heard that it may actually be beneficial for elderly patients to have a high blood pressure for circulating reasons. Is this true or not? All right, so the question is, and that's a good question, because a lot of patients say, well, I'm 80 years old and I should have a blood pressure of 180 over 70. And that really is a fallacy, because it doesn't matter whether you're 20, 30, 50, 60, 80, or 100. The ideal blood pressure is still 120 over 70. That never changes. Does that mean I try to achieve that in everybody? Absolutely not. It'd be ridiculous. You have to be more careful with the elderly population, because some of the medications that we use, like ACE inhibitors and ARBs, can make these patients dizzy, and they can fall and break a hip and other such things. So it's all about individualizing your therapy. So no, it's not great to have a high blood pressure. And if you are treating an elderly person with a high blood pressure, I do it more gradually. I never try to just do it. I'm very careful so that I don't cause falls and injuries. Great question. Let's see. I've never read Dr. Fung. Which books should I start with? He's got about 3 or 4 books out right now. But the good thing about Dr. Fung, I really like him, because he defines this so well. You can get him. You can go to YouTube. He's got an active YouTube channel. I think one book is called, I can't think of the name of it, but I really like him. And again, because he's worked with so many ill patients, he knows what he's doing. I mean, if you can take a diabetic with kidney disease and reverse things before they really get to end stage, it's really amazing. But again, fasting is not for everybody, and you really need to check that out with your doctor. And you may need to go to a functional medicine doctor, because I don't think your average doctor really is that knowledgeable about fasting and diet in general. So to me, it's a passion. Okay, let's see what else I see here. We talked about supplements. Okay. So intermittent fasting. So what you're doing, it's just fascinating. First of all, since I do it, I can speak from my own experience, and I'm fortunate to be in a 12% club. But for me, it's reduced cravings. Like, I almost never snack anymore. I mean, I have 2 major meals. Sometimes I may have 3, but usually I don't have breakfast anymore. Just not that I don't like breakfast. I actually do like it, but it's just not necessary. I'd rather have a long period from my dinner meal and have what's my meal like 12 noon the next day. It works for me. I have less cravings. I'm definitely leaner than I've ever been, except when I competed in bodybuilding, and I wouldn't call that healthy. And it definitely decreases your blood sugar. I do this thing called BioSense, which is a little instrument right here. I just happen to have it here, and it measures my acetone levels. Now, I am not ketogenic, but I have become, through intermittent fasting, fat adaptive. And I measure this throughout the day, before exercise, after exercise. And I have a fair amount of acetone that I can expel from my breath just by my everyday living. And I think it's because of my lifestyle. because I'm not strictly ketogenic by any stretch of the imagination. I'm not trying to achieve those levels. So it's really interesting. They can definitely help with blood sugar. Metabolically, there's no question that intermittent fasting can help. And so it's also the same with ketogenic diet. I mean, I am not ketogenic, but if I had real metabolic aberrations, I might consider it. So it's knowing what diet to use for what patient. Diabetes code. Thank you for the shrink shot for me. The diabetes code is an obesity code. He has 2 major books out, and he's got a new one that just came out, and I don't know the name of it, but that's the 2 major ones. Okay, how does a thin or underweight person benefit from intermittent fasting? I probably wouldn't recommend intermittent fasting if you're thin or underweight. That's when you really have to cut it. Like when you do this, when you do that. Eating disorders, no. Underweight, I don't think it would be a wise thing. These people tend to have a faster metabolism, and I probably would not recommend it. I would work with other modalities than intermittent fasting. That's just me. I'm sure some of these people have done intermittent fasting, and I haven't studied Dr. Fung's population of patients. I mean, a lot of his patients are pre-dialysis, so I think once you're in dialysis, you have a lot of muscle wasting, but I'd be very careful with the underweight population. What's a healthy complex carbohydrate? Okay, what is a healthy complex carbohydrate to consume that has a mild effect on blood sugar? That's easy to answer. None. Because whether it's simple or complex carbohydrates or carbs, they're going to break down to sugar eventually. It's true that if it's complex carbohydrates, it's going to break down slower than just simple sugar. But it's still eventually going to break down to sugar. So here's how I do it. Like for dinner, I have no carbohydrates other than vegetables. That's it. I have my protein, my vegetables, and I have a fruit for dessert generally. And that usually does it to me. I rarely have carbs. I mean, I never have them. If I go out, I may have them, but I routinely do not have a starchy carb at all with my meals after let's say after 2 p.m. If I was going to have breakfast, people ask me, what's a healthy cereal? There is none. Every cereal is processed. People talk about oatmeal, when I was in bodybuilding, I had oatmeal every single day of my life. So I don't care if I never see another bowl of oatmeal the rest of my life. It's complex, but it's still sugar. It's going to break down to sugar. But good question. All right. Let me see if I have not answered anything here. These are great questions, guys. Okay. Here's a question that someone asked me: how do you measure your waist circumference? What's the best way of doing it? Okay, so actually, even if you have a really protuberant belly, the best way to do it is take the tape measure across your hip bones. We can all feel our hip bones generally, right? So you put the tape measure across your hip bones, right above it rather, I'm sorry. And then you should be crossing at the midline, which is your belly button. Okay, and the best way to do it is to not hold your breath, but to like exhale, and you take it on the exhalation. So you don't hold your breath. You just breathe in, you breathe out, and that's where you take it, right at the level of the hip bones. And it's really important to know that because those numbers are like greater than 40 for a male, which is a lot of people in this country, and greater than 34.5 or 35 for a female. And women change after menopause. There's no question about it. Even if they've been normal weight most of their life, like I said, it's all about body composition. And unless you're doing strength training, it's going to happen, to a certain extent for most of us. So, but it doesn't have to be that way. Okay, what about the theory that overconsumption of protein leads to conversion to fat? Okay, that's another fallacy. First of all, fat doesn't convert to protein doesn't convert to fat. That is, I mean, if you have, okay, now your body is very smart. Your liver can do a lot of things. It can actually convert protein to sugar if it needs it. Okay, we call that something that's called gluconeogenesis. And that's physiologic. And that's because your brain needs to have sugar if you aren't ketogenic. So you're never going to deplete yourself of blood sugar because your liver can handle it. It can make that conversion. As far as taking protein to fat, that's really not going to happen unless you're eating so much protein, if your caloric intake is like huge, but that normally isn't an issue. But good question. I like these people, there's so many myths out there, and that's one of the things I try to dispel. Let's see. We're running out of time, but I got a few more minutes. So if there's anything else, I just want to make sure I have this whole list here. I'm scrolling down here. Fasting, diabetes. I think that I think that's about it. This is a great question. So listen, I want everybody to have a happy holiday season. Let's see. So 2 weeks would be Christmas Eve, and I don't think that's a great time to have a session. So, and then following Thursday would be New Year's Eve. So we will resume the first Thursday in January, in the new year. We're going to be talking a lot about diet. We're going to be breaking down diet to various components. We will be doing more about fasting. I'll have like programs set up for that. And if you have any suggestions, please, put them in the box here. Let us know. And because your input is very important. Because this is fun for me. And all right, so I wanted to sign out and wish everybody happy holidays and appreciate you guys. Okay. And we'll see you next year in 2021. Thank you. Okay, good.
Are you off?
Yeah.